Welcome to the Academy of General Dentistry podcast series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started.
Hey, welcome back, everyone. We have another great show for you today as we welcome Dr. Josh Austin to the program, and we spend some time talking about restorative dentistry. But before we introduce our guest, make sure you subscribe to our channel, hit the like button, and ring that bell. That way you'll be among the first to be notified of all things AGD. Hey, Josh, how are you?
Good to see you. How are you, Dr. Schmidt?
Doing fantastic. Really great. Really excited to have you on the program here. Looking forward to a great discussion. So let me tell our audience a little bit about you before we get started here. So Dr. Josh Austin's keynote performances from Dent Supply's Serona World to Seattle Study Club symposiums are met with rave reviews from audiences and conference organizers alike. Josh incorporates his trademark comedic style in his lectures across the country on topics such as mental wellness, new products, material reviews, and online reputation management. He's an editorial director and monthly columnist for Dental Economics magazine, focusing on dental products and technology. Dr. Austin has been honored with several awards during his dental career. In 2009, the Texas Dental Association named him Young Dentist of the Year, and in 2010, the Texas Academy of General Dentistry named him New Dentist of the Year. Dr. Austin has earned a mastership in the Academy of General Dentistry, and in 2014, Josh was awarded with a fellowship in the American College of Dentists for his outstanding commitment to ethics and patient care. Today, he maintains a full-time restorative dentistry private practice in San Antonio, Texas. And man, you got a lot going on. You're a busy guy.
I always hate like hearing bios just read because it's just, all the fluffy language that's put into it. But the thing out of all that I'm the most proud of is my mastership in the AGD. It's being involved with organized dentistry. You get a bunch of lapel pins to go on your jackets, right? And the only one that I wear is my pen that's my mastership in the AGD because I put so much work into it. And it's actually, honestly, the mastership in the AGD is why I am able to lecture and speak, because I did a master track with the Texas AGD. And probably Florida, I believe, has a master track. Yes, the Florida AGD.
They do, yes.
Several states do. I think California does. And it's really hard to do your mastership without a master track because of some of the, I'm trying to figure out what the right word is, some of the more limited hands-on CE opportunities like hands-on pedo and special patient care and ortho. To really get involved with the master track is the way to do it. And the way the Texas master track does it is you go back after the next session and you would present cases based on what you learned at the last one, and you would get more credit, and you could add a little bit of surgery here or perio there or whatever. And one of the directors of my master track after one of my case presentations said, you have some skill at this case presentation stuff. You should consider putting together maybe some lecture material. That's where it all started. That's where all of this started. So I have the AGD to thank for pretty much all of this. That's why it's my favorite organization.
Wow. Well, thank you for that. And yeah, Texas AGD does an amazing job. A lot of great friends down in Texas, and they do a fantastic job. And we'll have to thank them for sort of giving you your start in the business here. And of course, on that note, you're giving back because you're going to be in Montreal July 9th through 12th at AGD 2025. I think you've got a couple of courses up there, right?
Yeah, I think I have two hands-on workshops, one on direct posterior composite and efficiency with that, and one kind of an interesting course that you don't see very often, hands-on glass ionomer. So to me, glass ionomer is kind of one of the forgotten dental materials, but it actually has a really impactful place in your practice if you use it the right places and the right times, in the right situations. And there's also been a good amount of innovation in glass ionomer over the last 5 to 10 years. And so people who have just kind of tuned out on glass ionomer may be surprised to know all the opportunities they have to use it. And we're going to use some of those products in the hands-on and do some preparations and some restorations of different kinds, talk about applications of glass ionomer. So it's one of my favorite courses to give. I don't know anybody else who does a hands-on in glass ionomer, so it's a fun one to do.
Wow, you're right. I'm trying to, as you're speaking, I'm trying to think if I know of anyone that does that, and they don't. So we'll talk a little bit about that. I absolutely want to touch on that. Of course, we have a limited amount of time here, and so much we can actually talk about. But one of my most favorite topics. I teach I've taught at a few different dental schools over the years, And one of the things that I always try to instill in the students is there's really three things, in my opinion, that are going to make you a successful dentist. Clinical skills, of course, we take that for granted. That's what we're here. That's what we train for. Psychology and patient management, that's really, really important. But efficiency is one of the things that are not really talked about, and it's near and dear to my heart. And I try to instill, and I hope I do a good job of that. And I know you speak about that, and that's one of the things that one of the courses that you're given is posterior efficiencies. But how do we reinforce that mindset? Because it's almost a mindset of how to be efficient, how to get things done.
Yeah, it's a great point, and efficiency is really important. Number one, because patients don't want to be there, right? That's it. They don't want to sit through a 3.5 hour buccal pit, which is what we do our junior years at dental school. And that's fine. We're learning, and that's what it is. But patients, have busy lives. They've got a lot going on. They don't want to be in our office, and so they want restorations done quickly. In addition to, I don't know, I'm sure everyone else has felt it just like we have. It's all in the news. Everything is more expensive than it was before, right? And it doesn't matter who the administration is and what the Fed does and whatever, inflation and costs go up, right? So my cost of my supplies go up, cost of my payroll goes up, my rent goes up, my cost of my different liability insurances goes up, everything goes up. But the one stupid thing that doesn't go up is my stinking reimbursement rate from a PPO for a DO composite. And so the only way that I can stay as profitable as I have been in the past is to do more restorations. That's it, and to work more efficiently. And so we have to have strategies to get restorations done quickly, but still offer great clinical success, right? And with some of the innovations and materials that we've had and some new techniques, I think we can really begin to work faster and taking those number of minutes for a restoration down. So I say this all the time. Well, let's say this course makes somebody 2 minutes faster with their class two. Great. Like, I don't know, 2 minutes where you get an extra sip of coffee, you scroll Instagram for 2 minutes, check the score of last night's baseball game, look at the box score or whatever, check your fantasy football team. That's not about the 2 minutes for the one restoration. But if you take that 2 minutes for every class two that you do throughout a year, and that is actually a significant impact. It's something that's a book that I've read called Atomic Habits. That's like the small shifts that you make a huge impact. And so if you can shave a minute or two off every restoration you do, at the end of the year, that's a huge impact. So that's what we're talking about.
Yeah, I think a lot of people don't grasp that concept because, as you say, when we think of 2 minutes, we're like, 2 minutes, and you get distracted so easily. But if you think of that accruing over the year, that's an enormous amount of time and money, right? And time is money, of course, as we
For
know
sure.
that. What about, I know you're a big proponent of digital dentistry,
Yeah.
and, I'm going to say it's a must-have. I'm sure you'll agree with me.
Yeah. Absolutely. Yeah. I couldn't, it's one of those things I couldn't operate without, right?
Do you scan every patient that comes into your office? Are you taking a
Yeah.
full at the exam? Are you doing that?
For sure. That's to me, I had a call with a dentist from Georgia just now. That was kind of set up by a representative of a company, because my practice changed when we started scanning people in the hygiene room. So our office policy is we scan every new patient, and then we scan most of our adults. So if an adult has wear, amount of wear, any amount of recession, any crowding, spacing, malocclusion, they get scanned once a year. And in our practice, we do it in our non-bite wing visit. So the only time we're ever taking a scan and radiographs at the same visit is the comprehensive exam where we have more time. After that, it's just either scan or radiographs. And it's changed so much about our conversations with patients. It's really enabled us to have true co-discovery with the patient instead of us just telling a patient what they need and hoping that they trust us or believe us. We have the ability to show and prove, and get them to see. And it really changes everything from your conversations to patients to your case acceptance rate to the kind of dentistry you do. Really changes everything. And so that's really like when people buy a scanner, I think they buy a scanner to make crowns, right? That's why you buy a scanner. And that's fine. They do that and they do that well. But the real value of it is using it to enhance these patient conversations in order to get more yeses to dentistry, and you'll see your practice grow. And it will grow not just like in class two composites or buccal pits or sealants or that kind of stuff. It'll grow in like the things you want to do, right? Like the more comprehensive type procedures, the more elective type procedures. It grows in that kind of stuff. And that's really the value of buying a scanner, is using it to get conversion and case acceptance.
So I think you're absolutely right. Your practice is going to grow exponentially in every different direction when you do that. So, and a lot of people I think also don't think of that as well. I mean, and there's efficiency again, right? So you're doing bite wings one visit, you're doing a scan the next visit, and then every new patient. So all your auxiliaries are going to do that. You're not doing that, right? You're going to have them do
Right.
that.
Yeah.
And then do you collect all your information, all your data, and have the patient back on a second visit, or does it depend on the complexity of the case, or how are you working that?
Yeah, if it's a super complex case, it's going to be interdisciplinary where they're going to need some transitional bonding and then go to the orthodontist that day and then crown lengthening and a couple of implants and a sinus lift and all that kind of stuff. Then yes, that's kind of a separate conversation that we have at a different time. But for the vast majority of our treatment plans, we usually do it that same day. What I find is that using the scanner reduces the amount of words I have to use because I don't have to explain all of what we're doing or all what our plan is because patients can see things really well and they understand much quicker. And so most of the time, it's happening all in the operatory or in a consult room that's next to the operatory. And the ability to do things like outcome simulations, like where I can show a patient what they will look like maybe after clear aligner therapy or maybe after some veneers or something like that, really does shift that conversation much more away from like the single tooth dentistry and much more to comprehensive stuff. Because you'd be surprised what patients that you think would have never been interested in more comprehensive or aesthetic dentistry become really interested when you show them what you can do.
Yeah, there's no question about that. And are you using your scanner for digital dentures and as well as restorative?
Absolutely. Yeah, my favorite way to do digital dentures, and it doesn't always work, but it works a lot of the time, is if my favorite patient to do is someone who's got an old worn out denture, right? And so we take that denture, we reline it, and then scan both sides of the denture, do some photographs in the mouth, and we work with the laboratory that's pretty well versed in digital dentures. And most of the time, we can jump from that record. If they have a decent starting denture that's maybe just had some wear, if I do the scan, reline it, do the scan of both sides and the photos, we can pretty much jump to a 3D printed trial denture in one visit in about 5 days. And so then we try that in, make any adjustments. If we do make adjustments, we scan that and then have the lab either 3D print or mill that. My least favorite denture patient is the patient that comes in with when they don't have a previous denture. They have 17 previous dentures. Then they have a
Exactly.
huge bag of them. And like those are the ones like, okay, don't like those. Once a year, I'll get a patient that comes in, and it's almost always they have existing dentures, but something happened to them. The dog chewed them up, they got dropped and broken into a bunch of pieces, they got lost. Those were kind of starting fresh. I'll scan the arch with the scanner, have my laboratory make me a basically like a custom tray. Then we'll do the impression, scan the impression tray, take photos, and then move on the same kind of workflow. We're not quite at the point where we can scan the ridge and then jump right to a trial denture. We're getting there right now. It's we still need that kind of hydrostatic pressure on the tissue, but we're on the way with that. And I think digital dentures is going to be something that's going to make our lives way easier as we move forward.
Oh, no question about it. We had Brian Goodacre on the program a month or so back, and he's going to be up in Montreal as well.
Yeah,
And we had a great conversation about that. And there's no question that's the way things are going. I teach here down in Florida at Nova Southeastern now, and almost all the dentures are done digitally. And
excellent. I love to hear
it's
that.
amazing. Yeah, yeah. Our chair, Alex Bendian, is doing a fantastic job of sort of pushing the program in that direction. So let's get back to restorative dentistry. So
Yeah.
one of the things I noticed when I was reading sort of the course description there, and I've tried this many times over the years, and I've never been successful at it, is two posterior composites at the same time.
It's the worst.
So talk to me about that because it's for me, it's I'm doing one, I'm polishing and and I'm adjusting, and then I'm going to do the other. I'm not going to basically do.
Yeah.
And I'm assuming you're talking about MODO, back to back, or yeah.
Exactly,
So
exactly. I think it's the hardest thing we have to do in dentistry regularly. There's harder things we do. Converting a hybrid is harder, but we don't do that all the time.
right.
Temporizing veneers is harder, but we don't do that all the time. Of the stuff we got to do every day, doing like an MO on 13 and a DO on 12 is just like, it's so maddening
Yeah.
because your reimbursements rates are low to begin with. You're frustrated to doing this. And there's only really three ways you can do it. So the first way you do it is you prep one and then you fill one, right? And you're thinking like, oh, life is good. I'm looking great. No big deal. And then you go to prep your second one. And what always happens when you go to prep your second one, no matter what you try to do, you ding the first one when you prep the second one. You try to polish it out and it doesn't ever, never polishes. Then you go to floss it and like snaps a floss in half after you're done, right? And you're like, oh, this is terrible.
Yeah.
So then the next time you prep them both together at the same time, right? And like, oh, okay, I got this. This is easy. If that was the problem, let's just prep them both together. You prep them both together, and then you fill the first one, and you make the first one too fat and into the space of the second one, and you try to go down and smooth it down, and you never get it smoothed down all the way. And now you have this weird like C-shaped contact that frays the floss every time. So you really, the only other way to do it is you got to prep them both at the same time and restore them both at the same time. And the sequencing on that is really important. And that's kind of the secret sauce of how we sequence that. And that's part of what we'll talk about in both our hands-on and the lecture
Yeah.
at AGD in Montreal. But it really is just a maddening deal. I was taught to do quadrant dentistry in dental school as if it's some sort of huge ethical thing or whatever to do.
Right.
And it's
Right.
like, it really, every time I have like a quadrant of class twos, I'm like, who invented quadrant dentistry? I'd rather do 4 individual appointments for all 4 of these restorations and just have them be 20-minute appointments than one appointment of fighting all of these restorations back to back. But it's part of the deal. People are busy. They only want to come once. They don't want to come 4 times. So you got to do it, and you just have to figure out a new way to make that happen. And that's what we're going to go over.
Yeah, well, I'm excited to drop in and see that up in Montreal for sure. Yeah, because all of the things you described have happened to me, over the past years, and some more than others. And it's usually, the 4 o'clock appointment or the last appointment of the day, and
Always.
you're
Yeah.
tired and like, oh my God, who put this on my schedule? And so I think we can absolutely all relate to that.
It's
S-
when I see those quadrants, like when I see those appointments of 4 class twos all in the same quadrant, I go to ask my scheduler, like, did I say something that offended you? Like, what did I
Exactly.
do to deserve this? Like, this is not how I would like to have my day go, but
Oh gosh.
it's part of the deal.
Absolutely. So true. So when you're doing these restorations, are you using heated composites? Are you using flowable? What's your recipe there?
Yeah, so kind of a combination of all that. Heating composite, especially in the posterior, it really only does good things for you. So the first thing that it does, and when we say heating it, we heat it up to a specific temperature, 155 degrees Fahrenheit. Is kind of the magic number. And as you heat the composite, you lower the viscosity of it. So your typical like packable composite that you would, dispense out of one of those little compules, um, where it's pretty kind of waxy and viscous before you heat it. When you heat it, it just starts to flow a lot more. So it fills nooks and crannies really well. On a class 2, class 1 type situation, that can be really helpful to have it blow into all those little corners of the uneven box or the preparation. The second thing that it does is as we heat the composite, it uh, increases the depth of cure, and it reduces the curing time. So, meaning we can say fill an entire 6 millimeter box in one increment instead of having to layer it. In my opinion, layering composite while in the anterior, we need to do a lot of times for aesthetics and to get that like depth. In the posterior, all layering composite really does is give us an opportunity for bad things to happen, like contamination and a void, right? So I want to make my restorations as seamless as possible. So heating it up also reduces the polymerization shrinkage, which is great, and it increases the fracture resistance and the hardness of the composite. So really, only good things happen when you heat it for the posterior. You can also heat flowable composite as well. And if you think flowable composite is flowable, heat it up to 155 degrees and it becomes really flowable. And so we kind of do that all in one monoblock increment, a little bit of heated flowable, a little bit of heated packable composite, and then we fill our whole box up with that. And we get these like really seamless infinity edge bevel type of line angles and corners of the box that are just really, really hard and really well filled. And so it gives us a lot of huge advantages that can make us faster because we're not stopping to layer and whatnot in between. And it gives us a better restoration. So I'm a huge fan of heating composite. We'll do that at the meeting. We'll try some heated composite so that people can feel it and see how it goes. I don't heat in the anterior for the most part because with the anterior, if I'm doing a class 4 or class 3, I need some body to the composite to be able to shape it and layer it and all that kind of stuff. But in the posterior, I'd say probably 95% of what I do is heated.
Yeah, I'm a huge fan of bulk fill. I don't like to layer, like you said. I don't like a lot of
Yeah.
bad things can happen. Almost nothing good can happen there. And I think you make a good point. And I know you're going to do this in your course. Your course or others like it's really a great opportunity to feel these materials because you kind of feel this stuff to
Yeah.
sort of buy into it. It sounds like it's good. A lot of people are just going to continue doing what they're doing and layering because that's how they were taught, maybe. But I think that's really good stuff.
Yeah, I went to the University of Texas, and we had an old football coach named Darrell Royal. And Darrell Royal was a coach in the 60s, coached 3 national championship teams, and he loved to run the ball. Wishbone, that old deal, ran the ball. And he said, anytime you throw the ball, only 3 things can happen. 2 of them are bad, right? An interception or an incomplete pass. And I feel that way with layering composite, except there's not a good thing that can happen. Like, it's only bad stuff that can happen. It can only take you more time. It can only be contamination. It can only have a void. And so, that to me is like, if I can reduce the amount of layers I do, especially in the posterior, it just makes everything better for everybody.
No question about it. And it leads right back into being more efficient, right? You don't have to
Exactly.
stop and cure and all that kind of stuff. Absolutely. Josh, we're going to take a quick break so we can have a word from our sponsor. We'll be right back.
This AGD podcast series is sponsored by DHP, one of the largest family-owned full-service dental dealers in the U.S. DHP provides dental and medical supplies, equipment repair, maintenance, technology, and equipment sales to clinics and practices nationwide. AGD members receive exclusive discounts and promotional offers when they buy from DHP. We are especially grateful for DHP's continued support of AGD. Their partnership helps make this podcast and the vital conversations we share possible. Discover why like-minded general dentists work with DHP by visiting their website at www.dhpsupply.com.
Hey, welcome back, everyone. We're talking restorative dentistry here with Josh Austin, and we're going to pick right back up, Josh. So let's talk a little bit about bonding protocol and maybe some of
Yeah.
the things that have changed since, for instance, when I was in school 30 plus years ago.
Yeah.
Talk to me about that.
I went to dental school in the early 2000s, and my like restorative course director was a guy named Jim Summit, who's kind of one of the giants of operative dentistry. Wrote the textbook Summit's Fundamentals of Operative Dentistry, which most dental schools either use that book or they use Sturdivant's Guide to Operative Dentistry, one of the two. And I remember Summit walking in our spring of freshman year and teaching us all about how 4th-generation bonding agents were the king, and they would always be the king and the gold standard and blah blah blah. And our clinic at Texas recently, in the last probably 4 years, has switched to a universal bonding agent, to a one
Wow.
bottle universal bonding agent system.
Okay.
And so that really like opened my eyes of like, hey, it's time to really look at these. And these universal bonding agents, you can get different people on. Some of the guys like Nate Lawson and Taisir Suleiman, like some of the academic guys who are in Taisir's at UNC, Nate's UAB, and they'll argue about whether these universal bonding agents are 6th generation or 7th generation, or is it a whole new 8th generation? And at the end of the day, that really matters almost nothing to me. What matters more is the process of using these, right? And so I think with the 4th-generation bonding agent, number one, you have 2 bottles, which is fine, but each of those bottles is $150. So now when you equip an operatory for a bonding procedure, it's $300 off the bat, right? So that's one thing. And again, it's another step and another opportunity for bad stuff to happen, like contamination or overdrawing, things like that. And so it simplifies your process. The biggest thing about these universal bonding agents is that almost all of them, in addition to being able to be used for direct restorations, just like our 4th-generation bonding agents could do, they can also be paired with a cement. So the adhesive becomes the primer for the cement. And so now you just have one bottle that does everything adhesively in your practice, whether it be a occlusal composite of number 3, a DO composite of number 12, a crown, an inlay and onlay, a veneer, and everything in between, right? And so that makes things simpler for us, for the dental assistant. It helps our inventory control to not have to have all these different bottles. I don't know if you noticed, but every bottle you buy in your office is like $150, $180. So the more of those you have to have, the less frequently use the bottles, the more chance you have of using it incorrectly or not storing it correctly or having it go out of date. And so it just simplifies all the procedures. So big fan of universal bonding agents. Setting up your restorative protocol so that you're using the same adhesive for your direct restorations and your indirect restorations, which makes everything easier for everybody, saves us money, but also gives us really nice results because these universal bonding agents work really, really well. And if you have good technique on these, they can work just as well as a 4th-generation bonding agent in terms of bond strength and in terms of bond integrity and longevity of the restoration.
No question about it. And a lot of waste too with some of these materials, right?
For sure.
You're putting it out and and then you're throwing half of it
Evaporation.
away. It's
Yeah,
evaporating,
yeah,
all that
exactly.
kind of stuff. Yeah. So it leads right back to efficiency. So, um, walk me through your bonding protocol. Are you etching and using these, or are you just going to use the complete all-in-one, or using Gluma,
Yeah.
for instance? Talk to me about that.
So I'm a big fan of etching enamel in a selective etch technique. So we
Mhm.
use our 35% phosphoric acid etch only on the enamel with a rim around the enamel around the cavo surface margin. That's going to etch our enamel. We need that strong acid etch to etch our enamel, but that strong acid etch is really hard on dentin. Dentin and enamel are way different, right? Dentin's very fragile. And so if you just etch it with the strong phosphoric acid etch, you can over etch it pretty easily, in addition to activating these things that live in the dentin called MMPs. It's an enzyme that lives in the dentin that begins to degrade your dentin bond virtually immediately. And after 5 years, it's almost nothing. So if we avoid putting phosphoric acid etch on dentin, we can avoid waking up those MMPs and giving us problems down the road. So isolate a band of etch on the cavo surface margin, let that sit and set and etch, and then we rinse that, get the restoration where it's moist but not too dry, but not too wet, right in the middle. Then we scrub our adhesive in. In this scenario, we have etched our enamel, but we're relying on the gentle self-etch monomer that's in the adhesive to etch the dentin, and that works really well. When you do it that way, you don't need to use another product like a Gluma or glutaraldehyde or chlorhexidine, anything like that, because the point of those types of products is, number one, to inhibit sensitivity, which if you stop etching the dentin with a strong acid, you're going to get less sensitivity. And number two, to turn off the MMPs. Well, we haven't turned on the MMPs. So yes, if you're doing a total etch type system, I would definitely recommend a Gluma or a chlorhexidine or glutaraldehyde, some kind of product like that to be able to do those things. But if we haven't etched the dentin, we don't need to address that problem, right? So it saves us some steps. Rella Christensen did a lot of the work on Gluma, and she has the Christensen protocol for applying Gluma, which is great, and it works really well, but it basically adds 2 minutes onto your bonding procedure. So total etch, rinse, dry, scrub in your Gluma, scrub it in for a minute, hold your high volume tip over it to suction off the excess, then do that again, right? So you're adding
Yeah.
about 2.5 minutes, just kind of undoing what you did with the etch step, which was promote sensitivity and activate the MMPs. So again, working efficiently, we want to just, hey, let's eliminate that whole step. And that's what universal bonding agents allow you to do. It allows you to selectively etch your restorations, which is going to really diminish your dentin bond failure over time and your post-op sensitivity.
Yeah, great stuff. And I know you speak a lot about materials. Anything new and exciting on the horizon that's going to help us even more that you can think of?
Yeah, so when we certainly look at direct materials these days, we're starting to see an increase in these direct materials that have fewer shade choices, right? Which I think is obviously an inventory management thing. I look at my master shade kit that I use for like my interior composite, and I think it's like a fishing tackle box. It's got 36 shades, 4 different opacities. We use A2 all the time, but like there's A6 dentin. I can't remember the last time I used A6 dentin. I think George W. Bush was president the last time I used
Yeah,
A6 dentin.
yeah.
So you buy these big kits that have all this stuff in it, and then when we realize, like, all right, well, we just throw that away every 4 years, and then we don't want to be without it, because if we have that one patient every 10 years who comes in with that shade, we got to have that composite. Whereas now we're looking at these kind of systems that have maybe 3, 4, 5 shades. And basically you can blend those together, more of a value-based shading system. So we're going to see more value-based composites. I think that's really important. We're seeing an increase in ergonomically designed dispensing mechanisms. So ability to apply adhesive directly in the mouth without losing some to evaporation, and kind of these hermetically sealed applicating pens, things like that. Obviously from a digital standpoint, 3D printing getting better, better, and better, more in the office. And I think the integration of scanning and then design software like ExoCAD and 3Shape and things like that give us the ability to do some rudimentary quick design in the office, to be able to do things like provisionalize veneers or print a full arch of provisionals, stuff that's hard to do chair side, that takes a lot of skill and, quite frankly, a little bit of luck with draw and things like that. And so I think a lot of those things are going to get way easier for us as we start to incorporate those things. A mill, you buy a mill for your office, it's $100,000. You can buy a printer for your office for about $8,000. And so I think we're going to see a lot more dentists incorporating 3D printing and design into their practice, because the barrier of entry is just so low. And as the resins get better, it opens up our flexibility on those kinds of things. So really, really good expansion of what we can do and do quickly and reproduce for patients.
No question about that. And I'm still thinking about the box of composites that you were talking about, because I can't tell you how much composite I've thrown out over the years because it's expired by the time I use it. But again, you have to have everything.
That's right. And we feel incomplete if we don't. And we feel like we're bad dentists if we don't carry A6 dentin. And it's
Yeah.
like, all right, well, you're really not. Like if you had one, kind of value-based composite that was in the warm shade and then you layered over it with a type of enamel shade or whatever, you probably get the same result without having to throw away a 20 pack of it every 4 years after it expires.
So true, so true. Backing up to bonding, because like I said earlier, I teach at the dental school, and students are always trying to negotiate away using a rubber dam. And the first thing they want to do when they get out of school is throw away the rubber dam. But I'm assuming you're using your rubber dam for all your bonding materials.
So there's two things you need to know about me, George. Number one is I use every restoration I do is under a rubber dam. And the second thing you need to know about me is I'm a compulsive liar. Because there's only one dentist who does everything under a rubber dam, and we call them endodontists. And they're so high and mighty about it. They're so preachy,
Yeah,
but
yeah,
it's a
yeah,
standard of care. And I'm like, what are you guys bragging about? You put it on one tooth, okay? Don't like let's not get so excited about it. 99% of the time, their assistant does it for them, right? We're
yeah.
trying to isolate from like a second molar to a contralateral canine. And I guarantee you, if we told every endodontist that when they were doing an endo on number 13, they had to isolate from 15 all the way around to 6, they'd start saying really quickly, you know what, an isolite's probably fine. And so I get it. It's just the pragmatic practicality. We all know that a rubber dam is the best way to do it. The same way we all know that at dinner tonight we should go home and have grilled chicken and broccoli, right? But we don't always do what's best for us because it's hard, right?
Yeah.
And it takes the discipline and determination. So there's ways that we can work around it. I use a rubber dam about 50% of the time. There's some scenarios where I always use a rubber dam. That's why I'm doing 2 class 2s back to back because it just really helps me in those situations. I wish that dental schools taught more. My dental school, when I taught in restorative, our policy of our department was isolating from a second molar all the way to a contralateral canine, because that was what was required on the Texas board exam, and
Right.
we wanted students to be able to do that. The problem was is exactly what you said. We created generations of dentists that hated the rubber dam because they don't know how to put it on. They spend 45 minutes trying to put it on. They tear 11 of them. The patient hates it. They hate it, and so then they scrap it. I wish we could do better about teaching young dentists and dental students, hey, here's a quick way to throw a rubber dam on one contact, on one tooth to do an occlusal lingual composite or an OB composite. Here's a quick way to do it, apply a rubber dam to 3 teeth really quickly when you're going to do a quick quadrant. If we could, here's a split dam protocol where your one contact is isolated, but your other contacts are split dam when you have crowding or something like that, or a bridge or an implant that you can't snap it around. I just wish there was more education in that pragmatic rubber dam approach, and I think it would make things easier. We have a lot of cool isolation tools now, things that combine suction and bite blocks and or cheek retractors and high volume and saliva ejectors and lights and all kinds of crazy stuff. And so that gets better every year. But at the end of the day, like I think we all understand that it doesn't replace what a rubber dam does, which is real humidity control in a mouth. But Nate Lawson at UAB, I've mentioned him a couple of times. He'd be a great person to have on the pod if you haven't had him. Did a study of relative humidity in the mouth when a rubber dam was applied versus when an isolite was put in the mouth. And the actual relative humidity of the mouth went down on the isolite because of the
Really?
high volume evacuation that was incorporated into it versus the rubber dam, which was baffling to me. I could not, I would have thought it was the exact opposite. And so, I think we're going to see some more innovation there. Obviously, seen a lot of it so far. So, again, I wish I put a rubber dam on everybody. It'd be a nice thing to say, at dental meetings and to stand up and be prideful about that. But at the end of the day, 90% of us don't put it on every restoration. And I think that's fine as long as we have other strategies that we can use and we know when to put a rubber dam on when it's appropriate. And I think that's the right way to go about it.
Yeah, I appreciate your sort of walkthrough with that or discussion of that, because my question was going to be, how do you square a rubber dam and efficiency, and what are some of the workarounds? And I kind of think you covered everything in what you just said.
Yeah,
That's
when
where
you're
I was
doing
going with
multiple
that.
class 2s,
Yeah,
it does save you some time,
yeah,
especially if you can get it on in under 5 minutes. Now, if you're fighting to put it on and it's 7 or 8 or 10 minutes long and you're upsetting the patient and they're uncomfortable and all,
right.
that's a whole nother like patient psychology discussion. But I think if I can get it on in under 3 minutes and I'm doing 3 or 4 class 2s, great. It actually does save me time. But there are some other tools that we can use nowadays, some new things that do make our life a little bit easier in the isolation world that don't need to be applied the same way a rubber dam does.
Yeah, no question. Listen, we got a couple minutes left. Talk to me about glass ionomer.
It's a great material. It's the only material we have that chemically bonds to dentin. It ionically bonds to dentin. Nothing else we do really bonds. We call it bonding, but it's really just micromechanical retention when we do adhesive dentistry with resin composite or resin cements. So it does really well in situations where we have carious root surfaces, right? So if I've got a carious class 5 situation, to me, that's an automatic glass ionomer. It holds up really well. Obviously, our fluoride recharge and release. And there's a lot of studies that show, one in particular, that was a really nice high-level study that showed the retention rate of class 5 non-carious cervical lesion restored with the glass ionomer was like 96% retention rate at 5 years versus 50% retention rate for composite. And so if you're doing class 5 composites, I understand it in the anterior, centrals, laterals, canines, things like that, because of composite does look better, does polish better, it's more glossy, it blends better. But if you're doing that in the posterior, I just think glass ionomer is a much better choice. It's much more likely to be there at 5 years because the modulus of elasticity is much closer to that of dentin, so they don't pop out the way composites do. They flex a little bit, and that ability to polish composite and whatnot, does give you some advantages of that in the anterior. But beyond that, glass ionomer has the belt when it comes to posterior type situations. They work really well in situations where we have a deep class 2 box. We're down on the root on the class 2 box. Maybe somebody's had periosurgery or recession. You place that first layer of material as a glass ionomer down on the root and then restore it like a traditional class 2. Those do very well over time. So it's a matter of finding those right situations. Can I throw it into the occlusal of every class 1 and class 2? Obviously not. That's not what they're for. But if you have some in your practice, especially as we see the population go up, you're in Florida, right? I mean, there's retirees all over the place, and their caries risk goes up as time goes on. Their polypharmacy issues, things like that. Their xerostomia goes up. It's a great thing to have in your practice if you're treating either kids, high caries risk people, or geriatric type patients. It's a really phenomenal tool for those types of situations. And so there's other scenarios where we use them that we'll go over in the workshop at Montreal, but those are just off the top of my head some great ways to use them.
Yeah, and more forgiving in adverse conditions as well.
Absolutely, yeah. You get a little moisture in the floor of a class 5 with a glass ionomer. It's going to do much better than a resin composite would do in that same situation. So yeah, not quite amalgam as far as it's amalgam, you could be literally waiting and waist deep saliva and be fine. But with glass ionomer, when you have a little bit of that gingival crevicular creep or a little bit of heme that oozes in there a little bit while you're placing it, it's probably much better setup for success than resin composite would be.
No question about it. Hey, listen, what a fantastic discussion. We scratched the surface on all the things you're going to talk about in Montreal and everywhere else that you lecture. And I'm really excited about seeing you up there. If you could do us a favor, share your contact information for folks that may have a question for you, but also folks that might want to book you to come out and speak and bring these courses out to maybe to their master tracks or other places.
Yeah, for sure. Best place to reach me is anywhere on social media at Joshua Austin DDS, except for Snapchat, because I'm 46 years old. And any 46-year-old man on Snapchat is up to nefarious stuff. And I'm also not on TikTok because I take Lipitor, and they don't let people who take cholesterol medications post on TikTok. It's one of those things. So really, actually, Instagram is the best place to find me at Joshua Austin DDS. I do pretty good about checking my messages on there. So that's probably the best place to reach me. Also, email jaustindds@icloud.com. And I do have a lecturing website, austindentalseminars.com.
There you go. And I would encourage all our listeners to follow that up and take a look at those spots. Fantastic. Josh, thanks.
And come to Montreal.
Yeah.
Montreal is such an amazing city. It's like Paris. It's like being in Paris without leaving North America. It's a European city. It's great.
Absolutely. And we are so much looking forward to seeing you up there. And thanks again for coming on. Really enjoyed the discussion that we had here today. And I'd also like to thank our producer, Kristen Gover. If you like what you heard, please like and subscribe to our channel. You can always find us on Spotify, the AGD app, SoundCloud, Apple Podcasts, and on YouTube under @General Dentistry. If you have any questions, concerns, comments, or suggestions, please contact us at news@agd.org. Thanks again, and we'll see you next time.
Thank you.